Okay, so I'm Dr. Chad Shepherd, and I'll be presenting, talking a little bit about how psychology can help with managing pain and fatigue. I'll do the first half of the presentation, and then I'll pass over to my colleague, Dr. Natalie Levy. Okay, we've got 55 minutes, so I'm going to probably crack through at a brisk pace. Okay, so I'm going to start off by talking about I suppose, the science of pain in the body and how the body processes pain. And then we're going to talk about some of the factors that we know tend to maintain and influence chronic pain and fatigue. And then we're going to think a little bit about how us as psychologists can help with that process. You know, a lot of people come into our clinics, and some people have no idea why their consultant has suggested that they come for psychology. And so part of the assessment is an education process. So I'll talk a little bit more about that a bit later on. Okay, so we know that pain is a subjective experience, and it's produced by the brain. So we've got the neuromatrix. So some guys who were very prominent in increasing our education on pain were Meltsack and Wall. And they came up with this idea of the neuromatrix. So this is a kind of a representation which represents the interaction between brain cells, nerve impulses, and chemical releases, which produces a neural pathway which produces the experience of pain. So I'm going to refer to this probably right throughout the presentation, so I'll just talk you through it a little bit now. So, I suppose in the middle, that circle which says evaluate, that's the brain uses different types of information before producing the experience of pain. So on the right-hand side, when it's decided that pain is necessary, the response tends to be pain perception, and that could be any thoughts, emotions, or physical sensations that come up when we experience pain. Pain action, these are behaviours and coping strategies to deal with the pain. So this could be kind of like if we put our hand on a hot stove, our hand withdrawal. And also stress regulation. You know, often when we're experiencing pain, our stress levels go up. But actually, I'm more interested in the inputs. So if you saw this as a computer program, we know that you put information in and you get information out. So let's just look at the different types of information that the brain uses before deciding whether to produce this experience of pain. So in the middle, we've got the sensory aspect. So we're all quite familiar with this. If we receive a pinprick, that's enough for our brain to decide to produce a painful response. We feel it's quite a sharp, acute sensation, and we tend to draw our body parts away from that stimulus. Then we've got emotion. So we know that actually, depending on how we feel emotionally, can affect the strength of the pain that we experience. So we know that when we're feeling stressed, we tend to notice or experience pain as more disruptive or uncomfortable. When our immune system is low or depleted, we tend to experience pain more. And our hormones can also affect when we experience pain. But I'm going to talk a little bit, in the next few slides, I'm going to talk a little bit more about the cognitive side. So when I say cognition, I mean any sort of mental activity, anything that we do with our minds. And that could be wishing, hoping, dreaming, calculating, deciding, forgetting, all those things. Anything we do with our mind is what we call a cognition. Okay, so depending on how we're thinking about pain, depending on our beliefs about pain, depending on our memories or past experiences, these will all affect how the brain decides whether to produce pain or not, or how strong that pain response would be. Our personality, whether people have low frustration tolerance or high frustration tolerance, that will affect how much pain we feel. Psychological stress, if we've had something going on in our lives recently, such as a change of role, we've lost our jobs, or somebody close to us has had a bereavement, that's going to affect us. And attention. So attention is massive. I'm going to go on to give you some examples of these areas in a second. But attention is huge. We can do a lot as psychologists in thinking about the role of attention in moderating the effects of pain. Okay, hurt does not always mean harm. So there's an Australian guy called Lorimer Moseley, and he's done a lot in terms of pain research, but also making our understanding of pain much more accessible to the layperson without using all this kind of like this jargon. And he tells lots of stories. And this is a great story just to kind of like, I suppose, just to help you understand what the brain's doing before it's producing pain. So he tells a story and he says, I was in the outback with a bunch of people and I was staying in a lodge. And I woke up about 5 o'clock in the morning, really early, and everybody else was asleep. And it was a beautiful day, the sun was out, I could hear the birds and the animals. So I decided to take a little stroll. I thought I'd have a little walk to the river before everybody got up. So I'm walking along, I'm walking through this long grass, and I'm approaching the river, and then I experienced a sensation on my lower right calf. And he said what the brain would have done, it would have gone through a series of kind of like computations or evaluations. And it would have considered kind of like, where are you? I'm in the outback. What are you doing? I'm walking. What are you walking through? I'm walking through some long grass. What's just happened? I've experienced a sensation in my lower right calf. Okay. Have you experienced anything like that before? Yes, hundreds of times. It was a twig. No pain. Then about 2 hours later, he's back in the lodge. He's in and out of consciousness, and his leg has swollen to twice the size. Turns out he was bitten by a particularly poisonous snake called an eastern brown. Fortunately, he was about 2 hours away from the hospital, so he managed to get the antivenom in time and he survived. And then he goes on to say, sort of about 5 years later, I'm back in the outback and doing this walking expedition. And we're walking through this long grass, and I experienced this sensation on my lower right calf. And he said, it was agony, it was excruciating. I screamed. Yes, I screamed, and everybody around me were alerted, they were looking to see what had happened. He said, my brain would have gone through a series of computations. It would have said, where are you? I'm in the outback. What are you doing? I'm walking. Where are you walking? Through some long grass. What's just happened? I've experienced a sensation in my lower right calf. Have you experienced anything like that before? Yes. I got bitten by a snake that almost killed me. Pain. So they looked around, everybody looked around to try and find the snake so they could get rid of the danger, and it turns out it was just a twig. Okay. But it just goes to show how much the brain relies on context and how much the brain relies on this cognitive area before deciding whether to produce pain or not. Now that's really interesting because then us as psychologists can get involved in thinking how can we moderate the experience of pain by thinking about that area in the cognitive area. Okay, expectation. So we know that aspirin is a very popular painkiller. They sell billions of pounds of it around the world every year. But did you know that the form that the aspirin takes has different pain-relieving properties? So we know that coloured beads of aspirin in a transparent capsule are more effective than white beads in a transparent capsule, which are more effective than coloured oval beads, which are more effective than square beads with the corners cut off, which are more effective than just ordinary round aspirin. It's the same dose of aspirin. But because we have ideas about, actually, the top one being kind of like pharmaceutical grade, it has a different pain-relieving property. So our expectation will influence how much we feel pain. In a sense, this is the placebo effect. This is what the placebo effect is all about. Okay, attentional focus. Okay, so we're going to look at some kind of like brain scans here. Okay, so I'm going to show you two brain scans. It's the brain scan of the same individual in two different conditions. So here is a brain scan of somebody who receives a painful stimulus, like a pinprick, and he's asked to focus on that sensation. So here we go. So we've got brain activation, as you can see, in the part of the brain that's associated with the experience of pain. Okay, then in the second condition, he receives exactly the same painful stimulus, but he's asked just to divert his attention and focus on a sound, like of a bell or something like that. We've got a change in activation. Now, we know this person's listening to a sound because we've got activation in the temporal region. But actually, look at the part of the brain that's associated with pain. There's there's decreased activation. So again, we know that actually, if we can control our attention, perhaps we can start to influence how much pain we're experiencing. Okay. So, in a sense, the brain is using information and then just guessing about how dangerous that information is to decide whether to produce pain. So yeah, perception is the brain's best guess about what's happening in the outside world. Now with people with EDS and hypermobility, it can be a little bit more complex than that. So we know that it's often misunderstood. I mean, so many people who come in who said for years and years, the GP just said, it's in your head, or they're growing pains, or, perhaps you're just lazy. People who come, spent 10, 15 years, and, some of the work that I do with some clients is just to start off exploring some of the anger around just not being believed. But also we know that with people with EDS and hypermobility, it's not just chronic pain we're talking about. It's also acute pain. But the approach to treating chronic pain and acute pain is slightly different. And it's like, well, how do we know how to treat it if we've got both? And so some of the work that we do as psychologists is to to help the client really understand what's acute, what's chronic, whether to rest or not, or whether to keep going in a paced manner. Okay. So, suffering. Okay, so I suppose just think about this circle represents our total experience. And this might be the sensation of pain. As you can say that actually, the sensation of pain doesn't necessarily take up so much of our whole total experience. But when we look at the impact that that pain sensation has, we can see that actually that can pretty much dominate our daily lives. And we know that the impact of just that sensation of pain can be causing anguish, fear, depression, anger, hopelessness, worrying, and fighting. A lot of my clients say to me, if it was just the pain, I'd be okay, but it's everything that comes with it that's the problem. So there's this idea of primary suffering and secondary suffering. Now, we can only do so much as psychologists in terms of thinking about reducing the primary suffering, so we tend to focus on the secondary suffering, the effects that that pain is having. And if we can go some way into alleviating some of the suffering that the primary sensation is happening, actually that can mean a lot to people. That can be quite significant. That can mean the difference between not doing anything and then reconnecting with the things that we value. Okay, so the pain cycle. So a lot of you may be familiar with this. Yeah, it's there's a vicious cycle of pain and fatigue. Pete Moore, he talks about having a pain toolkit of coping strategies to deal with pain. He says, what's the difference between the pain cycle and the M25? It's easier to get off the M25. But it's just to show how difficult it is to break that cycle. So we've got pain and fatigue, which tends to lead to inactivity or overactivity, difficulty sleeping, and when there's that around, our body can't heal itself, it can't regulate itself properly. It can affect how much we eat. Sometimes we eat more, sometimes we eat less, we worry more, we've got frustration. It affects our social life, we're not going out as much. It can affect working. It has so many different impacts upon our life that actually all contributes to this pain cycle. And when we're experiencing all those elements of the secondary suffering, that by itself can increase our experience of pain. Okay, so let's have a look at some research. Okay. So some researchers were really interested about the people who are experiencing chronic pain, what could make a difference to their lives? So they did lots of focus groups, and they were asking people, what are the most important aspects of your daily life that are affected by pain? And so they came up with, enjoyment of life in general, tiredness, fatigue. Being in pain so much is exhausting. Your body's working kind of like 2, 3, 4 times harder than anybody else's just to kind of like cope with this pain. Emotional well-being. Weakness, when we're experiencing pain, we tend to use certain areas of our body less, we become deconditioned, and that can in turn increase our pain. And staying asleep at night. So, I run a pain group as well, and a lot of my the attendees of the pain group will say, it's difficulty sleeping, the pain's waking me up. And we know that sleep is so important because, that tends to be when the body repairs itself. So even if, as psychologists, we can increase the quality of the sleep, then at least we're giving the body a chance to kind of like to repair itself or to reduce what I call nervous system desensitization. So pain management programs based on cognitive behavioral principles are the treatment of choice for people with persistent pain and adversity, and it affects their quality and adversely affects their quality of life. Okay, and that's from the British Pain Society. So I'll talk a little bit more about CBT a bit later. So when we think about some of the outcomes from the pain management programs, okay, some of the research shows that it significantly enhances coping behaviours and beliefs. They've been found to significantly reduce distress and disability. And actually, even though the target is not necessarily to reduce the experience of pain, quite often when we're thinking about reconnecting people with values, giving really good coping strategies, people tend to report that actually their experience of pain has reduced. So when they've looked at some of the pain management programs and they've looked at the outcome, they've got some really good results. And they've noticed that even when they haven't targeted the pain directly, there's been a 14 to 60% improvement or reduction in the pain experience. 66% have returned to work. 65% have increased their physical activity. And there's been a 68% reduction in healthcare costs. So we know that these pain management programs can work. Okay, so you may have heard this word CBT. I mean, a lot of people who kind of like, I've heard of CBT, but I don't really know what it is. So I'll just talk a little bit about it. So what is CBT? So CBT is cognitive behaviour therapy. And it's called cognitive behaviour therapy because we largely focus on the cognitions that I was talking about earlier, how we think about pain, how we think about how pain affects our lives, how we think about our role in life and how that's changed, catastrophizing, any anxiety thoughts that I'll go into a little bit later. And we look at behaviours as well. Are we doing the best to cope with this pain, to manage this pain, so that we can reconnect with our values? And then one of the things that we do in the first couple of sessions when we're doing CBT with our clients is we start to do what we call a formulation or a conceptualization. And that's really just making sense of what's affecting suffering for that person, what's influencing distress for that person. And really what we're looking at are emotions. And that's the first question that we'll often ask. How are you feeling? How is this affecting you? Okay. And what is it you're experiencing? So, in assessment, I want to get a list of everything that's causing suffering to that person. Because I know some of the stories come in that say, okay, I went to my GP, but he was only interested in, he only had 15 minutes, so I could only focus on one symptom. When sometimes when we're dealing with many symptoms with EDS, that's not so helpful. Behaviours. What's happening? How are you coping with that pain? What do you do when you're experiencing so much pain? And of course, thoughts, cognitions. So, and all these are related. There's a reciprocal relationship between these. And of course, what's the context? Yeah. So social factors in the environment. What's happening around you? What's happening in your life? And are those factors also influencing how much pain or suffering that you're experiencing? Okay, so some of the treatment methods. So we use a range of, it's so vast, it's hard to kind of like pinpoint. We're going to talk about a couple of techniques a bit later on, but it's a very vast and wide field. We use so many techniques, but that depends on the individualized formulation for that person. And a lot of it will be to think about unhelpful thinking, unhelpful behaviors. And, in the first session, we'll always say, what are your goals? What do you want to get out of it? If you left in the last session with me feeling quite pleased, what would we have talked about? What would be different? So goals are really important because that gives somebody a direction to go in. And there's quite a heavy emphasis on rehabilitation, actually increasing activity, because if you increase activity, you're also increasing strength. And when you're doing that, the pain's not so dominant, it's not so in control. So some more specific techniques will be, coming up with healthy coping techniques, helpful thinking, and helpful behaviour cycles based on values. I do a lot of work about values. What do you stand for? What matters to you? What's going to take you forward? Because when people experience pain, they become so disconnected from their values that that's just feeding into that secondary suffering that I was talking about. So pacing and goal setting. So you've probably heard that word pacing before. My colleague Natalie is going to talk about pacing a bit later on, but it's so important. If someone's not pacing their activity levels right and they're getting into this boom or bust cycle, we know that that is not a great way to be managing chronic pain or chronic long-term health condition. Yeah, managing stress and anxiety about pain. So we saw in the neuromatrix that when we've got increased stress levels, that's increasing the experience of pain. So if we can teach people to manage their stress better, hopefully there will be a reduction in pain. Improving mood. That tends to be why people come into the session, actually, because they're not feeling great, they're suffering. And improving sleep, it's a big one. And we've got lots of techniques to improve sleep. And then, I know Dr. Philip Bull was talking about mindfulness yesterday. Yeah, increasingly we're using more mindfulness techniques in our work because it's so useful and it lends itself to managing a long-term health condition. So quite often we will do relaxation and mindfulness. And also, there are so many other psychological issues that can affect. I haven't talked about trauma or complex trauma where there's problems going back to kind of like childhood. There's so many different problems that can come up for people that it's complex. And here, within the time that we've got, we can only talk about a couple of those aspects. Okay, so what are some of the psychological factors that increase pain and fatigue? So, activity patterns, that's a big one. What's people's approach to activity? Now, I see a lot of people in my clinic who tend to have perfectionist tendencies. That can be like all or nothing. And as soon as people say that, you're thinking, kind of like, if you don't have pain or a chronic long-term health condition, that's fine. But actually, that's not great with a chronic condition. Because when we're talking about nervous system sensitivity, if we've got kind of like this all or nothing approach, this boom or bust, the nervous system cannot get a handle on what's happening in the body. And if we're all or nothinging and we're agitating a very sensitive nervous system, it tends to respond with either pain or tiredness. So approaching activity in a different way can be incredibly useful. So some people avoid activity for fear of damaging themselves even further. And that's why it's useful to get into whether it's acute pain or chronic pain and thinking about actually, can you tolerate some level of activity? Guarding parts of our body. If we've got an injury, we tend to tense the muscles around that injury, but actually that can also increase our experience of pain. Reduced activity. How many other things in our life have we, has taken a back seat because we're trying to deal with this experience of pain? And how does that affect our moods? And this boom or bust cycle that we're going to talk to you a little bit about later. And also focusing on pain. We saw that brain scan earlier where actually when you focused on pain, we saw how much activation there was in the area of the brain that's associated with pain. So focusing on pain, which is really understandable, actually is not so helpful. So if we can teach people skills to actually distract themselves or focus away from pain, that's going to be really useful. Yeah, and yeah, quite often we see people where their whole life at that time is dominated by this health condition or this chronic pain and fatigue. And really our work is thinking about actually, well, how can we sort things out so pain has less control, so you have more control about some of the things that you do. Yeah, and relationship with others. We do a lot of work about communication, helping people understand what it's like for us and helping people understand how they can support us. Okay, so some of the, I suppose in more detail, some of the psychological factors that can increase pain. So negative thoughts. Actually, I tend not to use the word negative, actually, because people then think I've got to generate positive thoughts. So I tend to use the word kind of like, it's either helpful or it's not. If it's not helpful, let's think about what we can do about it. But when we see in the literature about CBT, negative thoughts, catastrophizing about pain, that's just exaggerating how things will be in the future. It tends to be kind of like, this will never change. I will never get better. Hopelessness thoughts about pain. Okay, hopelessness will predict, depression. And also negative feelings, fear about pain, depression, stress, anger. Anger comes up a lot in our clinics, but understandably so. And poor sleep, yeah. Okay, so common beliefs, just before I pass on to my colleagues, so common beliefs which make pain worse. And as I put them up, just think about this for yourself. Do you have some of that? Do you remember having some of these beliefs yourselves? And just think about how helpful was it to have some of these beliefs. So we've got ones around coping. I can't cope with this pain. Okay. Having that thought sends a message to the brain, and it will affect how much pain we're in or how much suffering that we have. Function despite pain. So I need to wait for the pain to go before getting back into full life. Again, that's understandable. That's not so helpful, actually. Well, what if the pain doesn't go unless you do something? Why don't we try something first and then see what happens with the pain? Hopelessness. It'll never get better. And anxiety. Yeah, what will happen to my future? That's a really scary thought. And when we do some of the values work and the goals work, actually what we're trying to set up is, how can you achieve the future that you want, holding in mind that there is this pain or there is this chronic condition. And then damage. Am I damaging myself through activity? Yeah. My physio is pushing myself, but is that the right thing to do? So we can explore that in psychology. Okay. So now I'm going to just pass on to my colleague, Natalie.
Hi, thanks, Chad. So my name's Dr. Natalie Levy, and Chad and I work together at the Hypermobility Unit. So I'm just going to talk you through some of the details of pacing and give you some examples of people we've worked with, and also end with some ideas of, hopefully some ideas you can take away yourself and try. So, the hare and the tortoise. Thinking a little bit, thinking a little bit about how much energy you conserve, because so much is expected of people in their day-to-day lives, either at work, at home, other commitments, and it's very easy for people with hypermobility or EDS to give up so much energy and then just crash, the sort of boom and bust. So it's very much trying to think about pacing themselves. And then thinking about, on a long car journey, do you want to wait for the petrol, the indicator that says you're almost out of petrol to light up, or do you want to try and put some in before? So often, thinking about it, almost another way of thinking is a bank account. If it's your bank account for energy, that might be mental energy, emotional energy, physical energy. How are you going to spend that energy? How are you going to make sure that you don't run out of money or petrol? And why are you trying to water your garden with an empty cup? There's just nothing left. You're absolutely exhausted, in pain, and you've got to the point where you can't do some of the things you need to do. So a lot of that is thinking, I'll come to it in shortly, I'll talk in more detail, but psychologically, what adjustments do you need to make about how you think about yourself, your activity levels, your expectations of yourself? What adjustments do you need to make to be able to pace? But firstly, let's talk a bit about what happens when we don't pace and we are inactive, either because we're just sort of chronically inactive or because we've sort of done boom and bust, done too much, and then we've just crashed. So we know that getting deconditioned and losing fitness really has huge effects on the body. So, you start to see changes in the cardiovascular system within days, decrease in blood volume, an increase in resting heart rate, which can lead to all sorts of different symptoms, things like dizziness, but sort of less energy to do things in different ways. Negative impact on muscles. I'm sure people's physios will be telling them about muscle strength, tone, size, all gets reduced. So and then that's going to lead someone to be more tired. It's going to lead someone to maybe be making what we call, biomechanical changes, not using their body in the way that it should be used, maybe more pain. Joints become less stable, less coordination, balance. So, and bones become more weaker and more brittle, losing calcium. Older adults who are on bed rest for a long time, lose huge amounts of calcium through that. And this all essentially leads to a vicious circle for people. They're often, because the pain is getting increasingly worse, less and less energy, they find themselves napping through the day, and then that leads to disruptions to our circadian rhythms, the rhythms that tell us when to sleep, when to get sleepy, when to get hungry, thirsty, all those things. Our body loves routine, and actually if we start disrupting it, everything becomes harder. People find themselves not sleeping so well at night, a lot more fatigue, more pain. And often that can change the way we think. People often talk about brain fog, just doing something that they used to find, quite easy becomes a real struggle. So pacing. Ultimately, what we're trying to do, and this is a message that I know the whole team reinforce as well, particularly physios, is actually trying to get more control back as a person by pacing based on time rather than on our symptoms. Because what we know from all the research is that pain or tiredness will tell us to stop too soon or too late often. So if we listen just to that, we end up probably doing too little or doing boom and bust and crashing. If we do start to pace gradually, and it takes a bit of time for people to find their baseline, and I'll talk a bit more about how to do that, but they can begin to have a bit more energy in the bank to use for things, more motivation, sleep tends to get a bit better, strength of muscles and flexibility improves, and essentially people are doing and achieving more. So whether that's if they've been off work for a while, whether it's actually just starting with doing some voluntary work and finding that they've got some energy to do that, or whether they've got more energy to play with their children or their grandchildren, going back to what Chad was talking about with values, what is important to you as a human being, because pain can steal that from us. And psychologically, we know it's vital for people's well-being to actually try to take some of that back for themselves, so they are doing and achieving more, but things that matter to them as an individual. Having a better social life. Pain makes people feel so isolated, and then you have things that, it can feel difficult to say to people, I need to sit down actually, or I can't walk that distance to go to that place. So actually So often people become more and more isolated socially. So how people can reclaim parts of their social life back increasingly. And essentially to feel happier. And the aim is thinking about the sort of secondary suffering that Chad was talking about, how that can really turn up the volume on our pain. It can increase our fatigue. It can lead us to lots of sort of negative cycles. But, for some people, when they do start pacing, it's not just the secondary distress that gets less, but also they might have less pain and fatigue. I think it's always important for someone not to believe that is definitely going to happen. And actually, it can be more helpful for people to think, even if the pain and fatigue stay, what do I want to change about my life? How do I want to be dealing with it differently? But for many people, pacing does lead to less pain and fatigue. And less flare-ups. I think one of the really hard things about having a chronic condition is the unpredictability. That, you could be having a really good couple of days or an okay couple of days, and then you have a flare-up, and all the things you'd planned just go out of the window. And that makes people feel very out of control and helpless. So trying to gain some control back with pacing again. And the body, I was talking about some of the changes to the cardiovascular system, to the muscles, with, lots of inactivity, but actually starting to do more, but in a paced way. The body starts to build up more tolerance to tiredness and pain and less sensitivity, as Chad was talking about. The down-regulation of, the nervous system sensitivity, which is getting so easily triggered. And, not just thinking about POTS. We haven't had a chance to even talk about some of the... So not just thinking about pain, we haven't had a chance to even think about POTS or mast cell activation or some of the other ways in which our whole bodily systems are getting activated and how that links back with pain. So doing things regularly in a paced way really starts to help with the nervous system sensitivity and also help with some of those other things. So thinking a bit about boom and bust. Quite often people might have been struggling for quite a long time with doing too much followed by crashes. Or sometimes just not doing enough chronically, or sometimes chronically doing just too much and eventually crashing. So everyone's sort of activity pattern is different, but usually I would say boom and bust, the sort of doing more and then crashing, either spent with days in bed or hours in bed or just having huge flare-ups of pain and fatigue. And ultimately, if we think about that graph, that just takes us nowhere, and that is so demoralising. So it's helping people to think, okay, what would be our baseline? What could we do on a good day and on a bad day if we were to try to conserve some of this energy? And then once we found our baseline, how we could, maintain it for a while and then work up a bit and a bit more. So, we also work with both with adults and children and young people, and maybe a child that's been off school for quite a long time. It's no good them going back to school full time straight away. It's thinking about how they could start with a baseline of, lessons, 1 or 2 lessons a day, and making it to the end of the week. So they're not then only making it to a Wednesday. And then, when they've been achieving that for, a couple of weeks or so, what could they add in that would be really important to them? And actually something like break time is really important, so they get to see their friends and they're not feeling so isolated. And then sort of gradually increasing that. But psychologically, that's really hard often for people. Because if you've got certain expectations of yourself and others have certain expectations of you, how do you change that? So I think the first thing to do is trying to look at it factually and thinking, what can I do on a good day or on a bad day? And actually adding that together, we've got a bit of a rough calculation here, but and then dividing that by 2, minus 20%. Everyone's figures are going to be a bit different, but the idea that you then come up with something that on a bad day you're going to really need to push yourself to do, but on a good day you're going to need to hold yourself back from doing. Quite often people say to us things like, the crashes are worth it for feeling like myself or feeling normal or feeling I can do those things that I want to do, even if it's just for those few days or those few hours. Or it just feels so hard to push myself on a bad day. And it's really trying to, I think the first thing we do, people often talk about therapy or psychology as holding up a mirror to someone and actually together looking at that and for them to see what pattern is happening for them, looking in their mirror, that yes, they might be really, really pushing themselves to do something for their family, but then that leads to them crashing and not being around to do things the next day with their family, or being absolutely exhausted at work. And ultimately, so much of what we do with people is asking people to try to start being kind to themselves, to actually start to try to put themselves first, because often they've sort of put themselves to the bottom of the list for quite a long time. And actually see that doing this, pacing in the longer term, will mean that they will be able to meet their expectations more and they will be able to do more for others, which I'll come back to a bit later on. Also just thinking a bit about food. Often when we feel so exhausted, people just reach for the sort of, the nearest thing, the quickest, easiest thing when you've got no energy, but thinking a bit about blood sugar levels and what we need upon waking to help our blood sugars regulate, when we have peaks and troughs in our blood sugar levels, and trying to eat to, nurture our body. So we wouldn't work through the details of what someone's eating with them, but we would just help them see that it's another way in which they need to be kind to themselves and take care of their body. So we talk a lot about acceptance and what is some realistic optimism and what would be a helpful thing to try to adjust to and accept. And, for people, it might be asking for adjustments at work, which psychologically can feel hard if they don't want to feel different, they don't want to make a fuss, they don't want to be seen as someone with a disability, perhaps. But it might be things like having, quite frequent breaks, also so they can stretch and their muscles don't sort of tighten up too much. Adjustments to their workstation, asking for, working from home. Some people might start to go part-time or make other adjustments to their commute. Changing demands at home and in line with what they're capable of doing in terms of pacing, so they can maintain their baseline. And also how to manage other people's expectations, because quite often if you don't have crutches or something they can see, people forget that you're in pain. And, I think patients often talk about either I get too much sympathy, which I don't want, I'm sort of seen as a victim and helpless, or people just completely disregard the pain and fatigue. And I think often people can be a bit inconsistent. They can often do both. And that leaves people with EDS and hypermobility often not knowing where they are. And so I think it's really important to first try to think about your own expectations of yourself so you can set down those boundaries with other people. And you'll need to keep setting down those boundaries often because people forget. If you want to be able to pace and in the long run achieve as much as is possible. So this is particularly hard for people who've got really high expectations of themselves. And what we know from all the research literature is they're much more likely to burn out because they will do so much more. And they might feel that they're letting themselves down, they're letting others down, they're breaking their kind of what we call rules for living. And ultimately, we might help people see where those rules come from. What is it about the way they grew up, people around them, where they work that makes them feel they've got those expectations, and how can they adjust them to almost be their own coach, so they push themselves on their bad days, but they also pull themselves back from doing too much at other times. They don't do things perfectionistically. Or for other people, it might be more about feeling very helpless and they can't cope with pain or doing things, and that stops them from doing their physio. And it might be helping people to see how can you try to find ways to push yourself and to find more sort of resilience in different ways so that you could start to achieve some of the goals that you want, some of the things that are really important to you. And trying to get away from self-criticism. People often get into these kind of cycles, and that just leads to lots of the secondary suffering that Chad was talking about. So one of the types of therapy approaches to this is something called Acceptance and Commitment Therapy, ACT. And it's what we call third wave CBT. It's sort of a newer version of CBT. I know Dr. Philip Ball gave a talk yesterday on mindfulness, and it's a mindfulness-based therapy. The idea is that we don't need to believe our thoughts. We don't even need to fight them often. We don't need to get pulled into them, because our thoughts will influence what we do so much. They might make us do too much. They might stop us from doing our physio. They might stop us going out. They might make the pain feel, it might add panic to the feeling of pain, and how we can actually really start to pull back from it. So I suppose attending to or dealing with thoughts and other experiences such as pain in a different way. Trying to actually just step back. Often the idea of metaphor is used, like maybe you're in a train station and there's lots of trains just going by, and the thoughts and the feelings and the pain are all on those trains, and you can just stop and you can just watch them rather than getting pulled in and believing the thought, I can't cope with this, my life is over, the physio's not going to work, those kind of things. These are the things that people commonly say to us that they think and feel. So I suppose it's about helping people to let go of unhelpful thoughts. Now, these are all such understandable thoughts to have when you've been in pain for so long and you're exhausted and all the other aspects that EDS, and hypermobility can involve. But it's about thinking, is this helpful to me? And recognising when it's unhelpful. So it'll never get better. It's understandable for people to think that when you've been feeling that day in, day out, the pain. But where does that thought take you? I can't cope with it. Again, understandable, but what does it lead to for you? Does it sometimes lead to you not doing your physio or maybe not going out for the walk you need to do to build up your stamina? And I suppose I would say, thinking about practical things people can take away with them is thinking about your own individual psychology, your own cycle. We all get into unhelpful patterns all the time. And what would be a more helpful pattern for me? What would lead me nearer to my goals? What would help my body get stronger? So rather than thinking as thoughts as true or false, it's trying to act acceptance, commitment therapy, we think a bit more, they're just judgments. So, with a young child, I might say, you know what, we can have, a thought is just a thought. So we might have a silly thought, it might make them laugh and think a bit differently about the pain. We could have a thought, the Queen and her corgis are about to, walk in right now. That's just a thought. You just won the lottery. That's just a thought, just like the thought this is never going to get better or I won't be able to carry on working or whatever it is just a thought. Problem is when we believe that unhelpful thoughts is they take us right down into cycles. So people I know who've been recovering from feeling down or depressed can actually find that the depression lasts longer if they start to think, why am I feeling like this? Why am I thinking these thoughts? I'm always going to feel depressed. I'm just a really negative person. And they get stuck in this loop that all the research shows makes the depression or the pain or whatever that negative feeling is stay for longer. So I'm just going to go through this quickly because I think I've got 5 minutes left. It's thinking about maybe one of those thoughts on the previous slide and focus on thinking, if that thought was true, it'll never get better. How does that make you feel? What would that make you go out and do if you're having pain? And then maybe thinking, I'm having the thought that it'll never get better. How does that make you feel? And then thinking, I'm noticing that I'm having the thought, like almost that idea of just trying to step back, think of it like the trains going past or often leaves on a stream, that they're just going by us. Now, I'm just introducing these to you quickly, but you need to have a bit of time and space, certainly the first few times you do this. So maybe one of the things you could sort of, if people are interested, is trying this exercise at home when they've got some time, is just noticing how stepping back and just observing our thoughts and feelings and accepting them and not fighting them, just noticing how it makes us feel. And I've got some links to resources at the end which will really help you put this into action. Thinking maybe a bit about, it's your 90th birthday and someone stands up to say a few words about how you learned to manage this pain and fatigue. What would you hope the person would say? If you can't change the physical feelings you're having, how would you like to be able to manage it? And again, these are just some ideas maybe you could come back to later. They should be, I think, on the website, they'll be sending on the video. How are ways to motivate yourself to change if you feel you need to. Lots of you may not feel you need to, but what would happen if you carried on as you are? What would happen in 5 years' time? What would happen in a year's time? And just really trying to think about that. So I'm going to talk very briefly about a female with EDS hypermobility who had a lot of pain and fatigue since she was 22 and understandably feeling anxious about the pain, but she also became very hopeless about physio, was in that classic boom and bust, I have to maintain my standards, and that led to crashes, not sleeping well. And the first thing we did is we tried to understand her cycle. That what was happening for her individually, with a particular focus on, it's disappeared, I'll talk you through it, with a particular focus on the effects that was having for her physically. If she wasn't then doing physio, she was getting more and more deconditioned because she had more and more pain, more tiredness. And then thinking how to break that. So, first of all, her understanding her cycle, her understanding some of the science about pain and fatigue. And then thinking about her goals. Hers were to have more energy, feel less stressed, and do a bit more, going for walks, museums, more time with the family. They were things that were important to her. There were other things that were less important that she didn't want to use her energy for. She wanted to conserve her energy for these things. And she essentially started becoming her own therapist a bit, noticing when she was getting into unhelpful cycles and noticing when thoughts would make her start to do too much. A thought like, you know, I really ought to help this person, and otherwise, you know, I'm not being kind, or they're going to think badly of me. Hopeless thoughts about not doing physio, that's a really common one, but then people don't do the physio, or they don't maybe give it the chance it could do, and then their physical situation stays the same. Whereas actually physio, I suppose it's about realistic optimism. What's the best place I can get to with it? We looked at changes she could make in her sleep routine, and essentially different strategies, whether it's based on mindfulness, ACT, traditional CBT strategies, relaxation, lots and lots of different ideas that we, I suppose, pick and choose from to help someone individually. Ultimately, to change the behaviours and to get into better patterns. And also help others understand that this is the new helpful pattern they're in, and they need others to help them manage that. So hopefully, let me move you on to the next slide, because I've got some resources there that you know, there's tons of things out there, but these are all good ones. The top one has lots and lots of CBT handouts. And different meditations. The breathworks, mindfulness courses are really useful. But probably as a first start, I think this book, Mindfulness for Health, which is a practical guide to relieving pain. It's very practical. You can work through one chapter a week. It comes with a CD with the meditations. Patients often find that really helpful. So there's loads of things out there to try and find and to try to help with the situation.